Yeah, I agree, Peter. That was a wonderful talk. Thank you. I've been asked to, I'm Neil Binkley. I'm from UW. I've been here about as long as Joe Shaker's been involved with Bone Club, which is pretty much from the beginning. And I've been asked to discuss the Endocrine Society vitamin D guidelines. Can you see my screen?
Yes.
These are my disclosures. The relevant disclosure, as per always with my talks, is that I'm going to give you a bunch of my opinion, and that is depicted by the purple text color. I'm guessing that you're all familiar with this paper. It was published this July in the Journal of Clinical Endocrinology and Metabolism, and this is uh, and I'm just trying to hide some things here unsuccessfully. Um, what their objective was to develop guidelines for use of vitamin D to lower disease risk in people who didn't have or do not have established indications for vitamin D treatment or 25 measurement. They directly said this is not meant to apply to people who have established indications for receiving vitamin D, and therefore it's not appropriate, or they don't apply to most of our patients with osteoporosis and fracture. I'd remind you that they also don't apply to osteomalacia and rickets. And in fact, the Endocrine Society guidance, not this paper, but the Endocrine Society does recommend calcium and vitamin D as an adjunct to osteoporosis therapies. What did they do? Very, very briefly, they got together a bunch of experts. They looked at RCTs in general populations. They defined empiric supplementation as giving more than the DRI, and they used the formal grade process. These are their recommendations for empiric vitamin D supplementation, and very basically, they said supplement folks from 1 to 18, supplement folks 75 and older, people who are pregnant, and people with prediabetes, and don't supplement anybody else. Okay. Then they went on to say, we're not going to endorse 30 nanograms per mil. And then they went even further and said, we're not going to endorse anything. We're not going to endorse any kind of 25D level to define low, kind of low, or enough. And then they had this companion paper where they published this paper called Vitamin D Insufficiency and Epistemic Humility. And when I looked at that, I said, okay, the folks at Harvard are smarter than I. What is epistemic humility? And so I went to the source of all knowledge, the internet and Wikipedia, and this is what Wikipedia says on it. And it basically says we can't do a study of the entire world. Instead of trying to be right, try to be less wrong. My Wisconsin synthesis of that was we don't know. And what they then went on to say is they said there's not clinical trial level evidence to support any distinct cut points. They then went on to say, we're not denying that thresholds might exist. We don't know what they are. And then they went on to advocate for additional research to assess what these cut points might be. Great. But that's if we get additional research. That's going to take years. And frankly, I'm fearful it might not happen. Uh, Funding agencies, notably NIH, has dumped millions of dollars into vitamin D research. I've heard grapevine that they are not very interested in doing more vitamin D big studies. We may not have anything new anytime soon. And so where does that leave us as clinicians? And this is exactly what I think that they could and should have expected using the grade process. And many of you know Sheldon from the Big Bang Theory. Sheldon has a famous quote that says, I have informed you thusly, not I have told you so. But Haney and Sempos have told us this. We shouldn't be surprised. This is what we should have expected. And so this is a wonderful editorial that the late Bob Haney published 12 years ago now. where he said how much vitamin D is enough is going to remain muddled as long as we focus on meta-analysis rather than on biology. Well, what did he mean by that? And basically, he meant that we need to know where we start. And if you're deficient in any nutrient, and in this case, vitamin D, giving more of it is going to have a benefit. Conversely, if you've got enough, giving more is likely to produce a null effect. And if you've got plenty of it, the only thing you can do is cause toxicity. And then he went on to say, well, duh, this is obvious. And it should be concluded from simple inspection of the curve, and we shouldn't even need to say it, but the world has largely ignored Haney's guidance. Moreover, Chris Sempos, the leader of the vitamin D standardization program, has been telling us for years that we need to compare apples with apples, not apples with oranges. And the reported 25D from laboratory A, B, and C are not necessarily the same. And he went on to say, without 25D assay standardization, we're never going to be able to develop informed consensus cut points. And in a different editorial published 4 years ago now, he went on to say it's time for funding agencies and journals to demand standardized 25-hydroxy-D, and failing to do so will perpetuate paralysis. I would suggest to you that having no definition of low, no definition of normal, and no definition of high sounds like paralysis to me. So we should have expected this. Moreover, in addition to flawed RCTs and imperfect assays, we don't really know what vitamin D analyte to measure. We're assuming that 25D is the right one, but this might not be correct. We don't know if everybody needs the same level of whatever we're measuring to define deficiency. And we need to remember that 25D is a negative acute phase reactant. And very briefly, many of you have seen this slide. This is just making the point that what we're measuring here at 25-hydroxy-D is swimming in a sea of vitamin D metabolites, some of which have a, quote, vitamin D-like effect. Examples include chole and 24-25. And 24-25 is present at pretty high concentrations. And I frankly wonder if different concentrations of these metabolites explain why patient A with a 25D of 15 has an elevated PTH and patient B with the same 25D does not. I think it's probably these other metabolites. But short term, we're going to measure 25D and assume it's the right thing to be measuring. But even the USPFTF told us that it's unlikely that there's a single 25D level that defines deficiency for everybody. I mentioned the negative acute phase reactant. This, I think, is a real deal. Here's a wonderful study of 9 patients who received endotoxin, and they measured 25D, and within 3 hours after starting the infusion of endotoxin, the 25D went down by 20%. So it's clear that inflammation lowers 25. This was published in the COVID era, but I think the authors got it right on, and that there's this multitude of other acute illnesses or events that cause the circulating 25D to go down. And I think it's this reverse causality that may well explain the multitude of associations of low 25 with virtually every human disease. So a causal relationship is that the risk factor causes the disease. Reverse causality is that the disease causes the risk factor. And relating to 25D, a causal relationship would be low 25 causes the illness, whereas the reverse causality is the illness causes the low 25D. And I think the clinical take-home is don't measure 25D in people who are hospitalized and sick, including those post-hip fracture. Importantly, this is a picture of Joe Shaker in his younger days. We often lump pharmacologic dosing of a hormone, vitamin D, with daily supplementation of a deficiency of D. And this was a really nice, I love the title, Bolus is Bogus. This is a narrative that was published a couple of years ago by Richard Mazies. Dr. Mazies was the founder of the lunar densitometry company here in Madison. And basically, this editorial reminds us that huge bolus doses of vitamin D elevate CYP24A1, elevate the 24-hydroxylase, and degrade vitamin D. So in essence, we're working against ourselves with the huge doses. So what do we do? Well, I think it makes sense that we recognize that our genes look a lot like these hunter-gatherers. And therefore, we can use the 25D levels of lifeguards to tell us what's normal. And if we do so, what is normal? And this was a study that we did about 20 years ago where we recruited these kids off their surfboards. On average, their level was 36. This was a study that they went into sub-Saharan Africa and found the last few hunter-gatherers on the planet. They were on average 46. And I think, therefore, clinically, if we use these folks to define normal, we should target 30 to 50. That often requires 1,000 to 2,000 units of D. My bet is that the bone organizations are going to largely ignore what the Endocrine Society said and retain their prior 25D values of 20 or 30 nanograms to define low. I think that's real reasonable based on the surfer data. We're in the process of retrospectively standardizing the surfer data. And when we do that, of these 93 kids, practically none of them were below 20. Practically none of them were above 60. To me, that says that human normal is 20 to 60. Just to remind you that the bone organizations have not changed their vitamin D recommendations. I'm not going to read this for you, but ACE and BHOF have stayed basically with what we've had before. Clinically, remember that there's variability of all of our assays, and the vitamin D standardization program recommends that our 25D assays perform with a CV of 10%. What that means is that if you get a 25D level of 30 nanograms per mil, your patient's true value is somewhere between 36 and 24. And how do we translate that into clinical utility? Aim a little high. And I don't care if you believe that 20 is right or 30 is right and some other value is right. But if you're thinking that 30 is right, it might be as low as 24. Therefore, aim a little high. And even if it's 36, you're not going to be pushing beyond what we can achieve by sun exposure. So you're likely not going to have toxicity. And that leads us to consider what in blazes is toxicity. And I've always been taught that vitamin D toxicity was calcium toxicity, hypercalcemia. But this really nice study out of Calgary says maybe that ain't so. And they did this nice small 3-year RCT of people who were really vitamin D replete. Their baseline levels were, as you see here, over 30 nanograms per mil. And then they gave them 400, 4,000, or 10,000 IUs and measured their bone mass by high-res PQCT. And at the end of 3 years, you see that the 10,000 IU dose, daily dose, had greater bone loss than the other two. Haney told us this. If you've got enough, taking more, it can only cause toxicity. But how about falls? I've heard there's a lot of stuff out there that maybe vitamin D toxicity causes falls. And in fact, this recent publication says there's mounting evidence that when you get above 40, maybe 60, that might increase the risk of falling. And to explore a little bit further, this is a post hoc analysis of Joan Lappy's 4-year randomized trial of vitamin D supplementation of 2,000 IUs. These data were pooled on a yearly basis. Falls were collected by diary. The gist of it is that from 20 to 60 nanograms per mil, there was no increase in fall in more than one fall in purple or 2 or more falls in red. There was a statistically significant increase in 2 or more falls above 60 nanograms per mil, but even with a data set of almost 6,000 people, only 2% of study observations are up here above 60. I think the jury's still out, but I find this reassuring that you can go up to 60 and not worry. So to summarize, where are we at? Vitamin D is important for bone health. Unsurprisingly, didn't show you these data, but vitamin D doesn't reduce fractures in folks who've already got enough vitamin D. However, we want to define vitamin D. It's likely common because we're not outside producing vitamin D in our skin. We should not screen the population. Test high-risk individuals like the patients that most of us see with osteoporosis and fracture. I think much of the association of low D with every disease on the planet is due to reverse causality. The mechanism is unclear, but the take-home is don't measure it in folks who are sick. Don't expect evidence-based guidelines to figure this out. We're going to have to use common sense, I believe, for the foreseeable future. Supplementing with 1 to 2,000 is reasonable. Huge bolus doses are almost never needed. Aim for the 25D of surfers, 25 to 60. Vitamin D might, or it might not, contribute to the development of a whole flock of diseases, and deficiency of any nutrient is probably not a good thing. And I thank you, and I'll be happy. I think we've got enough time maybe to take a couple of questions.
So Neil, I'll start while people are putting stuff in the chat. When this was presented at the endocrine meetings, and then the paper published, it changed my practice zero.
I agree.
I don't treat patients that don't have a reason generally to measure vitamin D. So it had zero effect on my practice. It's just a comment. Now there's a question here. Vitamin D of 60 could actually be higher than that. Someone saying, Jenny F. So maybe we should set an upper goal of 50 to 55.
Yeah, I think that's reasonable. 100 years ago, my mentor told me that human physiology was smarter than doctors. George was right. The surfers, virtually none of them got to above 60. So I think that, shooting for 30, 40, 50 is fine. I don't think we should push to 60, 70, 80.
So yeah, I've been just using the 30 to 50 for now because
Yeah.
it's reasonable. And because being more than that might raise urine calcium or do some other things. If they're higher than 55 or 60, I ask them to cut back a little, and there's probably no harm to that. And so I think this is what Neil says so beautifully and clearly, and makes sense to me as a doc, is that we have to just be docs. We have to take care of our patients and do what's reasonable. I have one other question. Is there any nutrient where too little or too much is not possible? I tell my patients that all nutrients are like Goldilocks, because I also have a fair amount of patients with vitamin D levels of 120 who are taking 10,000 units a day for some reason in the post-COVID era. And I tell them that's for certain bad. But I don't think there's any nutrients, even water. Too much is bad.
Well,
I
so
don't.
that's the example that I use is water. Water's a pretty benign fluid, and you can die of hyponatremia and seizures from water intoxication.
Yeah.
So no, I don't think there's any nutrient that toxicity is good.
So Jod has a comment. He says, unfortunately, this goes out to the general practice, and they're thinking it means not to supplement people with bone disease. And I think we just have to educate them. I'll let you comment on that.
No, I agree. I think that I'm guessing Jod would say this hasn't affected his practice at all. It hasn't affected mine. But we live in a soundbite society where the soundbite is the Endocrine Society says don't use vitamin D and don't check 25. I think we need to remind the people that these recommendations do not apply to folks with osteoporosis and fracture. I see that Gigi's got a comment
Yeah,
here.
good
She's got
question.
patients with a 25D in the hundreds, stopped everything and it didn't go down. I don't believe that. The half-life of 25D is 2 to 3 weeks. If you stop the input, I think it's going to go down. Um,
The only thing I would say is check it by HPLC TMS.
and she
To,
says
to
she
make,
did. She checked it with
oh,
LCMS/MS.
she did.
So,
Okay.
I
Oh,
I
I see it. Yeah, I'm sorry. I
I
didn't
I
see
don't
that.
know. All right, I think in the interest of staying on time, let's move on. Our next presentation is going to be by Kristen Hare. Kristen Hare really has been and still is the heart and soul of the FLS and BHO program here at UW Orthopedic Bone Health, and she's going to talk about bone health optimization. Kristen?